So welcome back to our Psycho-oncology session. My name is Nomonde Mbatani, and I'm with Rakia Saidu, and we have our facilitators with us. But a special thanks needs to be given to our supporters and exhibitors, and we know this conference would not have been possible without the main sponsors for the conference. Our diamond sponsor is the National Cancer Institute, and our silver sponsors, it's Electa, Novartis, Takeda, and Varian Medical Systems. Our bronze sponsors, American Cancer Society, Beckman Coulter, Bristol Myers Squibb Foundation, CAF8, as well as the International Gynecological Cancer Society, that is IGCS. Thank you to all these sponsors for making today possible and the rest of the conference possible. Thanks.
Yeah, thank you. Welcome, everyone. This is a special session, and it's going to address distress in oncology as an essential component of care. And the facilitators for this session are Chioma Asuzu, who is the head of clinical psychology in the University of Ibadan, and Melissa Harry, who is an associate professor at McGill University and Jewish General Hospital, and is a psychologist in the Department of Oncology. Over to you guys.
Thank you. It's a pleasure and honor to be here. I want to introduce the idea of screening for distress for cancer patients with a special note to oncologists. The goal of psycho-oncology is to improve the quality of life of cancer patients, but also to make the oncologist practice easier and more efficient. We are not proposing to add another task to the oncologist's already busy schedule. What we're asking is for oncologists to advocate for trained staff to screen for, to evaluate, and to address patients' psychological distress. Many times when we give these presentations, we hear from oncologists and clinicians that they already are too busy, and it seems like we're asking them to take another 20 minutes to evaluate every patient for distress when they don't even have that many minutes for their oncology tasks. And specifically, that's not what we're asking. In the ideal situation, clinically, if a oncologist recognizes that a patient's experiencing high levels of distress, they should be able to acknowledge that and just say something like, I see that you're suffering. We have trained staff here who can help you with this. And then be able to hand the patient off to someone who can further evaluate and just deal with the patient's distress. The result is a better patient outcome, and it takes less time for the oncologist. The idea is that distress screening and counseling is not what oncologists were trained to do. And research shows that patients do not always reveal their distress to their oncologist. Many patients have a sense that that's not the oncologist's job to deal with emotional issues or pragmatic issues of cancer treatment. And studies have shown that when oncologists are asked to address these issues in their clinical practice, they're actually not very sensitive to it and not very specific. Studies have shown that, like I said, patients don't always reveal to an oncologist what they might reveal to someone else who's trained for that screening or more of an anonymous survey. Other studies have shown, both in the United Kingdom and in Japan, that if we train an oncologist to be more sensitive to patients suffering, what happens is the oncologist suffers and does not do well. So we're specifically not advocating that we have screening programs that make physicians and other medical professionals more aware of patient distress without having any means to actually do something about that. Thank you very much for having me here. I turn this over to Chioma Suzu to further elaborate.
Thank you, Scott. That was a great introduction, and welcome everyone to our symposium. So I would like to introduce Dr. Chioma Azuzu, Professor of Clinical Psychology and Psycho-oncology from the University of Ibadan. She's a specialist advisor to University College Hospital in the area of psycho-oncology. She's the founding president of the Psycho-Oncology Society of Nigeria and the Association of Psycho-Oncology in Africa. Furthermore, she is the vice president of Aortic West Africa and executive member of IPOS. She's been an amazing capacity builder of psycho-oncology in Africa. It's been wonderful to work with her and the team. So I leave the floor to you, Chioma, Dr. Azuzu, for your talk.
Yes, the topic of my presentation is proving cancer patients' clinical outcomes by attending to their distress. And that's the outline, looking at the concepts, assessment of psychological distress, distress assessment, conducting distress assessment, barriers to distress assessment, importance of distress assessment, the 6 vital signs, aims and outcomes. This is map of Africa, and that is where the AUTIC, Africa is, AUTIC is African Organization for Research and Training in Africa, and it's comprised of so many of these countries. I am from Nigeria, West Africa. Then this is Nigeria, and in Nigeria, I'm from the south part of Nigeria, and that is Ibadan. After Lagos, you will get to Ibadan. Then this is a pictorial illustration of University of Ibadan entrance. University of Ibadan is the foremost university in Nigeria, which was established in 1948. And university has 17 faculties and 92 departments, including Department of Radiation Oncology, which is where unit of psycho-oncology is domiciled, and also Department of Counseling and Human Development Studies, and where also is my base department. This university is the first university in Nigeria. Then this University College Hospital, the foremost hospital for tertiary care. And this is the university that takes care of takes care of oncology care in Nigeria. And many patients come in from neighboring African countries. Then I want to illustrate the picture of Jimmy Holland. Jimmy Holland is founder of Psycho-oncology, founder of International Psycho-oncology Society. Jimmy Holland is an amazing person and who brought psycho-oncology to Africa, you know, and he's the one that introduced us to what we are doing now. And so whenever I have opportunity to talk about psycho-oncology or any topic in psycho-oncology, I want to give honor to this amazing lady. May her soul continue to rest in peace. Amen. So concept of distress, cancer diagnosis, treatment, create a lot of burden for patients and their caregivers, and which may impact on their health, their function, their coping, and quality of life. So assessing distress of patients on both outpatients and inpatients is a positive step to steadily improve their clinical outcomes care on a regular basis. Psychological distress in cancer patients has been identified as a significant and ongoing problem in patients. And National Cancer National Comprehensive Cancer Network, NCCN, Distress Management Panel, has defined distress as a multi-determined, unpleasant emotional experience of psychological nature, which has cognitive, behavioral, emotional, social, and spiritual components. And this may interfere with ability to cope effectively with cancer, its physical symptoms, and its treatment. Substantial percentage of cancer patients suffer from psychological distress to severe mental disorders and psychological crises during the course of ailment and cancer treatment. And there is a great need to assess distress on cancer patients. And distress has been recommended by International Psycho-oncology Society as 6 vital signs. Whenever we come to the hospital, we do temperature, pulse, respiration, blood pressure, pain assessment. Distress assessment is one important sign that should be done to all the patients, because it is very, very important. Then we have continuum of care of this thing. We can look at it at every point of time, care, any continuum. Distress assessment is very vital. We look at the preventive sessions when we are in the community. We do distress assessment because patients are anxious about even the outcome of our screening. They are already afraid about what will happen. Even at detection, at diagnosis itself, patients have distress because you don't know what happens. When you hear the patient has cancer, they are very afraid. They are already thinking that death may be the next thing to happen to them. And during the treatment, we know that cancer treatment is not a joke. From surgical treatment to chemotherapy to radiotherapy, they are all things that give emotional distress to our patients. And so we need to screen them, we need to encourage them, we need to put them on treatment, even at survivorship states. They are anxious when they come to yearly assessments to know how they are. They are also anxious. We need to also take care of them even at that point. Palliative care also, and even at the end of life. And so this is a picture of the distress thermometer, which is one of the scales we use in assessing distress. Talk about that. And what are the assumptions preventing psychosocial disclosures in patients? That's it, because raising difficulties is seen as the responsibility of doctors, not patients. So doctors, patients may not even have time, even when they are in the doctor's office, to say, this is their difficulties, this is that. Patients and relatives sometimes lack the confidence, the social skills, the language to ask questions from healthcare professionals or express their feelings. Healthcare professionals are seen as too busy and important to be burdened with patients' concerns. Patients feel constrained by the common social pressure to think positively all the time. Patients may feel ashamed at admitting that they have particular difficulties, especially sexual difficulties, financial difficulties, literacy difficulties, especially in our own environment, in our own African environment, Nigerian environment, where they are not so confident to express themselves, where we know that patients, especially with cervical cancer patients, may feel so intimidated to express his or her sexual needs, or to even express that the demand that the husband is having on her because of the sexual difficulties or inability to have sexual intimacies as to when due. And so this is part of the assumptions of things preventing disclosures. Then assumptions preventing disclosures in patients. Those bearing guilt about their previous lifestyle may also feel reluctant to ask questions, especially those who have been smoking and they have cancer of the lungs, so they may have difficulty and they're already having guilt. Complaining about side effects to staff, the staff may think that they are nuisance and they are not ungrateful, they are always complaining. Emotional and even physical distress are often seen as inevitable and untreatable. Patients worry that they may be labeled as mentally ill, morally weak, or regarded as they are not coping. Assumptions preventing introducing psychosocial discussions in clinicians, poor distress detection skills among healthcare workers. Oncologists expecting patients to raise concerns if they have them, just like patients expecting oncologists to raise the concern, identify this. Poor communication skills resulting in blocking patients' attempts to communicate their concerns. 7 principles of distress assessment. When you want to assess distress, we make it clear that it's a normal routine assessment rather than something unusual. We make the entire process transparent to patients, explain the purpose of these tests and what we need to achieve from it, enable them to see that they are right, what you are writing on the assessment sheet, build rapport and trust them, expecting that the patient can talk about themselves. Take time and talk generally about how things are going to go, what this distress thermometer is all about. Show them the picture and explain the distress thermometer to the patient. When discussing their concerns, move from general to specific. Emphasize patients' own resources in managing their difficulties. That patients, the fact that they are patient does not mean that they are not intelligent enough or they don't have skills or to manage certain things. We need to acknowledge their achievements and how far they can also help themselves. Make it a solution focus rather than becoming bogged down with the problem. Assessment is not therapy, but nevertheless, an opportunity for patients to tell you about themselves. And during the process, it can even also bring down the stress or whatever that the patient is passing through at that particular time. Scales used in distress assessment. There are different scales, like I've talked about thermometer, distress thermometer, which is the universal, the simplest scale that you can use. And it's very user-friendly. It's pen and pencil assessment scale. Hospital anxiety and depression scale. This scale, we use it regularly in this environment. So many of our patients know about, of our oncologists know about it. Many of our oncologists or healthcare professionals know about it and they can use it easily. We also have brief symptom inventory and the MD Anderson symptom inventory. We also have Kessler psychological distress scale, distress assessment, and response tool. There are various scales that one can use depending on where you find yourself. In our environment here, I'm talking about in Nigeria, in my center, we use most of the time distress thermometer, followed by a hospital anxiety and depression scale. We also have mini mental status examination, depression scale, rating scale, anxiety scale, coping mechanism scale, stigmatization scale, spirituality scale. It depends. We start with distress assessment, depending on the components where the problem of the patient is coming from. We may now do HAR scale. HAR scale will give us the picture of the distress or picture of the anxiety or of depressive symptoms. Then follow up, we can use other depressive scale or we use anxiety scales to find out what the problem is. Then administering the distress thermometer, we look at the preparation, the timing, the setting, the consent, and the communication style. Steps in psychosocial distress, we look at the screening, evaluating, referring, follow-up, and documenting and quality improvements. Conducting distress assessment stage 1, we, like I've said earlier, explain what you want to do to your patient. Distress assessment is a paper and pencil scale which ranges from 0 to 10 score. Scores of 4 and above should be further evaluated. Ask patient to look at the distress assessment picture on the left, explain what it represents, and ask the patient to rate himself what he thinks is his distress level. Then go through the items of the other practical problems maybe family problems, maybe emotional problems, maybe spiritual problems, of physical challenges of that patient. Accommodation-wise, because here in our environment, like I said, that UCH is a tertiary institution and is domiciled in the western region of Nigeria. And so we have patients coming from south, coming from the northern region, coming from the eastern region to access care in this place. And they may have some of these problems. They may have accommodation problems. They may have financial problems. And we may need to look at those ones. Patient can add any other concern on the problem list. And at the end, we rate these things, rate them and make the consider the top 4 concerns. And then after that, like I said earlier, we can use other scales to further help these patients. Then problem solving. There are 3 options for addressing patient concerns here. Some concern may be resolved immediately by further providing information and referring the patient to where the patient needs to get care, like pain assessment and all that. Some concern may be resolved through the patient taking personal actions, which we are the ones going to also help the patients. Some concerns may be dealt with by referring the patients to other mental health professionals, spiritual leaders, dietitians, depending on whenever the patient comes. If the concern of the patient is bordering on the spiritual side, like in our center, we have chaplains, and these chaplains are made up of from different religions. We have the Muslims, we have Muslim leaders, we have the Christian leaders, and we also have the traditional people. We also have those who volunteer. We also have Catholic priests who go around to meet the needs of these patients. And after, let's say 6 or 7 on the score, we can also, the psycho-oncologists may take up these patients. And of course, we also may refer to psychiatrists if need be. So in follow-up is another thing that we don't just leave it. We continue to follow up the care, follow up the outcome of the distress on the patients. And also the clinicians also will also continue to follow up with these patients, follow up with instruments like nurses. Nurses are the best group of personnel who can really do this assessment, because they are always there with the patient. They spend 24 hours in the facilities. And so it's always good for psycho-oncologists to collaborate with the nurses, and so that the nurses can help in doing this follow-up. They will also do follow-up reevaluation and find out where the patient is, and also give appropriate treatments. We have some barriers. Some barriers may be in a busy oncology centers, maybe lack of time, self-confidence in skills assessment, lack of experience in investigating distress, and also using psychometric instruments. Experience of psychological distress is not only to patients, but also to the caregivers and to other significant family members as well. So focusing on only the patients, no, because the caregivers suffer a lot of distress, because they are the ones that go about, go and pay dues, go and pay hospital dues, move from, go and collect one test result or the other. By the time they come back, they are already very exhausted. So screening, managing and reporting the distress or other psychological needs is, however, not part of the routine clinical nursing practice in most cancer centers. But one of the recommendations we need to give, that we should incorporate it, institute it as a comprehensive care to all the patients. One of the barriers to providing psychosocial care to patients is also reluctance to reporting emotional sufferings, as have been identified in research. Some of the aims, why do we do this? We provide a brief holistic care about this patient, biopsychosocial, spiritual assessment of this patient, you know, what the patient is passing through. We also do this to document the patient's physical state and experience of side effects pain, nausea, fatigue, psychological and emotional well-being, as well as any interpersonal concerns like anxiety, fear, depression, unhappiness, relationship issues, sexual and other family concerns. We also are able to identify social and practical concerns such as housing, finances, need for information. We also, it helps us to identify existential concerns such as spiritual crisis, life regrets, to identify services and resources that may help to resolve patients' concerns. Distress assessment improves outcome. According to Hemelich et al., distress assessment helps patients to openly admit the need for distress assessment, which may pave the way for counseling for psychotherapy. Distress assessment affect the quality of life and social functioning. This could be identified through assessment so that appropriate targeted psychological therapy will be administered to the patients. It also improves survival in some patients, survival rates of some patients. It also improving this survival makes the patients even the little time to write their narratives. This is what I want to be remembered for. Even if the time is not so long, but it will help them to improve their narratives. It helps them in improving coping mechanisms, to cope with life challenges. It also enhances the quality of life of the patients. And after all this, we also give psychological intervention through good communication, through psychoeducation, cognitive behavioral therapy, group and individual psychotherapy, stress reduction exercises, and mindfulness cancer care, which Linda will expose us to this. And this is part of the care that we expect psycho-oncologists or mental health practitioners to help to give these patients so that they could recover and enhance their quality of life. In conclusion and in discussion, distress assessment at the 6 vital signs should be integrated into the care of the patients. It should be incorporated as one of the things that patients need to have done. And that will lead to psychosocial care of these patients. All patients should be screened for distress at their first visit and also as clinically indicated. The importance of distress assessment on mental health of the cancer patient cannot be overemphasized. It's a numerous, like I've earlier enumerated, that it is very vital because it improves their quality of life. All cancer centers should incorporate distress assessment as part of the holistic care in order to enhance the quality of care and quality of life of cancer patients. And we want to recommend that what it means is that many of the healthcare professionals should be trained in this area. And that is why I made this presentation. Even listening to it today, you should be able to go back and say, what is this distress? How can I start it? How can I go back? How can I talk to my CMDs? And that is why in talking about these things, we always encourage us to seek for political will, because speaking to our CMDs, our head of departments, they will be able to help to understand the importance of distress assessment as the 6 vital signs and the importance of psychosocial care in enhancing the quality of life of cancer patients. It cannot be overemphasized. Thank you very much for listening. I'm happy to make this presentation. Thank you.
Hello. So I guess we will take questions from the audience, and you can use the chat box to ask any questions that you may have on what was presented so far. So we'll just wait a few seconds if there are any questions. If not, then we'll just continue on with our next presenter. All right, so I guess we can continue on, and Chioma, you can present our next presenter.
Okay, hi.
Oh,
There's
I'm
there's a
sorry.
question.
Oh, I'm sorry. I
Hi,
think
Melissa, there's a
we have
question here. And the question is
Yes,
from
thank you.
Shelley. She said, thank you for the insightful presentation. Once the distress assessment has been conducted, how are the contributing factors to the distress assessed? For example,
Addressed.
food insecurity, accommodations, etc. Have you found that these assessments increase the expectations of the caregivers upon its administration?
Yes, when you assess this distress, like I said in the presentation, you will present whatever you have identified to appropriate quarters. For instance, for accommodation, we have social workers, and social workers are part of our psycho-oncology team. And so we have social workers, we could refer them for accommodational assistance. And so that's how it goes. And so, for instance, in the University College Hospital, we have an accommodation where we could help patients with, especially patients who are coming from very far areas. And so the social workers are in charge of those things. Again, if you identify that the problem of this patient is coming from emotional, like identify, it means that you will assess again using the hard scale to find out whether the problem is more of the symptoms of more of anxiety symptoms or more of depressive symptoms. And on that side, you will look at offering, asking for the assistant, referring this one for a psycho-oncologist or a clinical psychologist who will help this patient to administer psychotherapy, depending on the appropriate one at that particular time. But even some of our nurses could also do a little bit of sucking therapy. But if whatever you've gotten is higher than 7, 8, this candidate may be, after psychotherapy, we may also refer to a psychiatrist. Okay, so whatever the problem is, wherever the problem is emanating from, there is a solution focused to it. It's my pleasure to present Dr. Linda at this virtual AUTI conference. I met Dr. Linda some years back, and I attended her workshop, and I enjoyed it. So Dr. Linda holds the Enbridge Research Chair in Psychosocial Oncology. Is an Abata Innovate, Health Solutions Health Scholar, full professor in Psychosocial Oncology in the Department of Oncology, Cummings School of Medicine at the University of Calgary, an adjunct professor in the Department of Psychology. She is the Director of Research and works as a clinical psychologist at the Departments of Psychosocial Resources at the Tom Baker Cancer Center. Dr. Carlson's research in mindfulness-based cancer recovery has been published in many high-impact journals and book chapters. Dr. Linda Carlson is somebody I like to listen to her workshop all the time. And I welcome all the listeners, all the participants to please enjoy this presentation. Thank you very much for accepting to present at this AUTIC virtual conference. Thank you, and you're welcome.
Thank you, Chioma, for such a lovely introduction. Hopefully it looks like you can all see what's going on here. I'm just going to adjust my screen. Oh, let's see. There we go. Yeah, so I wish I had a map, actually, because I really appreciated seeing Chioma's map of Africa and where she was coming from. I know we have people all over the world here, and many of you in Africa. And so I am coming to you right now from Canada, in the western part of Canada, in the Canadian Rocky Mountains near the city of Calgary. And right now it is 7:30 in the morning, and we are starting our winter. And so it is dark outside right now and fairly cold. We have had snow, but recently it's melted. So maybe that gives you some context. So the discussion around distress screening was excellent. And Chioma mentioned that there's many different interventions that can help people with cancer cope with distress, anxiety, depression, and existential issues. And so mindfulness-based interventions are one of those approaches. And I'm going to take some time today to introduce you to mindfulness and also tell you a bit about our program and some of the work we've done. So I'll talk to you about what is mindfulness, how do we sort of think about it, conceptualize it, and then programs that train people in mindfulness. So the most well-known is called mindfulness-based stress reduction. I'll tell you a bit about that. And then focus in on our program called mindfulness-based cancer recovery, specifically for people who've been diagnosed with cancer. So I'll describe the program to you. I will talk a bit about the research. I could do that for hours. I understand this is an audience that's largely clinicians and hoping perhaps for some practical advice or ways to apply this. So I won't belabor the research. I'll talk about the whole curriculum for our program, which goes over a period of a couple of months, and how you can get training to be an instructor in this area. All right, so what is mindfulness? I don't know, and I wish I could interact more with the audience. I don't know how many of you are familiar with mindfulness, but it's been very popular in the media, especially in North America these days, and almost touted as like a cure-all for everything, right? So let's take a step back and really talk about what is mindfulness. So it's a simple definition. We talk about paying attention on purpose in the present moment with an open and accepting attitude. So it's kind of two things. It's a way of being in the world. We can always be more or less mindful, no matter what we're doing, right? So it doesn't take extra time to do things in a present, focused, kind of centered way. But it's also a practice that we learn, a skill that we have to develop. So this cartoon illustrates the idea of a way of being in the world. So I often say you've got the human, their mind is full of all sorts of things that aren't happening in the present moment. But you've got the dog, and the dog is right there. So I often say the dog's winning the mindfulness contest compared to the human. And then this just illustrates a way of being in the world, the practice of mindfulness, where we actually set aside time through meditation to train our minds in the capacity to be more mindful. All right, so if we're not paying attention in the present moment, what's our mind doing instead? And so researchers have sort of tackled this question in various ways, and it turns out we have anywhere from 50 to 70,000 individual thoughts running through our mind every single day. And so they've given people phones or pagers and beeped them randomly throughout the day and asked them, what are you doing? What are you thinking about? How are you feeling? And through that sort of method, we've been able to show that about half the time, people are not in the present moment. And when I ask audiences this before I show the number, they often say, oh, I'm only in the present moment 20% of the time or 30% of the time. So when you're not in the present moment, your mind's wandering to the past, the future, just dwelling on things, making plans. And the other part of this that's really important is that when people reported being in the present moment, no matter what they were doing or how they were feeling, well, no matter what they were doing, they tended to feel happier in the moment. So no matter what they were doing, if they were just making breakfast or at school or work, if they were paying attention and present in the moment, they felt happier. So then the next question is, well, why might that be? Well, let's think about what our mind does when we're not paying attention to the present moment. So for a lot of people, you might be thinking about the past, right? So this woman, she's feeling sad and depressed, and maybe she's thinking, oh, why me? Or if only this, if only that, why, that she's reliving some kind of event or experience and feeling sad and maybe regretful, maybe even angry. So she's in the past, right? She's ruminating on things that she can't change and feeling sad. Or you might be like this guy, right? He's rushing off to the future. He's thinking about, oh my gosh, all the things that might go wrong and all the stuff I have to do, and how am I ever gonna wrap my head around this? He's feeling overwhelmed and stressed out. So ruminating on the past leaves you feeling sad and depressed, and worrying about the future leaves you feeling anxious. And so you miss that present moment when your life is actually unfolding. So the emphasis on mindfulness is about being in the now, being in the present, rather than dwelling on yesterday or tomorrow. So academically, we break mindfulness down into three components. So we call this the IAA model. It's the why, the what, and the how of practicing mindfulness. So why is your intention? Why would you want to do this practice? You have to have an intention. You have to do it on purpose, because our minds are not typically wired this way. We're trained throughout our lives to be unmindful. And so we need an intention, a purpose that and this can vary. It might be, I just want to be awake and aware and engaged in my life. It could be, I want to help manage all the difficult symptoms I'm going through with cancer. I want to feel better. I want to make peace with whatever is happening in my life. I want to be more engaged, or I just want to sleep better, right? So there's some intention for the practice, some reason why you want to do it. And then the core of the practice is what we do. We're training attention. We're building the capacity to pay attention in the present moment. And that's a skill. So it's useful to think about this as learning a skill like playing piano or a sport of some sort, tennis. Say. You're not a piano virtuoso because you listen to music or you read books about it, or you just want to be a good piano player. The only way to cultivate the skill of playing the piano is to play the piano. You have to practice your scales day in, day out. Mindfulness is the same. The only way to become skilled and train your mind to be there in the present moment is to practice it every day, ideally, if you can. So that's what we call attention training. But we can't forget how we approach it. So that's the attitude. We have to be open, kind, non-judgmental, accepting, and I'll review some of those attitudes in a moment. But if we're harsh and critical of ourselves, it's counterproductive. The attitude is going to make you feel worse about yourself, because you'll notice as you start to do this, and we'll do it in a moment, that your mind's all over the place. We call it monkey mind. It's jumping from branch to branch, right? And so if we become critical and say, oh, I can't do it, it's impossible, it just leaves us feeling, undermined. So let's get all these attitudes up. So let's talk a bit more about these specific attitudes. So I mentioned non-judging, right? So our minds are quite judgmental typically. We like it, we don't like it. Oh, this talk is good, I'm going to go do something else. I wish things were different. So there's always these judgmental thoughts coming up. So we want to notice that first of all, and then look at the consequences. When I'm judging myself, when I'm judging my experience, how does that make me feel? And then begin to step back a little bit to just recognizing things rather than labeling or judging them. And having patience around ourselves and our practice. It's a very kind of fast-paced, fast food society where it's like, I want to relax and I want to relax now, right? You want it to happen immediately, but learning a new skill takes time. So we need to be patient with ourselves and our minds. Acceptance is really important, accepting our experience. In fact, mindfulness is often called an acceptance-based therapy. And this is different when we're dealing with cancer than just sort of giving up or giving in. It's more seeing clearly that we may be struggling, that we may be angry, we may be sad, we may be fearful, and accepting that as your experience, because it is your experience, right? So rather than pushing things away, allowing them to come and go. So the next one, letting go, actually is letting go of trying to control everything all the time and things that we can't control. So a recognition that the only certainty in life is change and going with the flow a little bit, non-striving. So letting go of that need to achieve things, just being in the moment, trusting yourself, your own intuition, your experience. And this idea of beginner's mind is seeing things as if for the first time with a sort of childlike delight and innocence. Children, they're really in the moment, right? They're really seeing what's in front of them. And we lose that often as we get older. We become cynical and kind of jaded. So we go through these and other attitudes when we train people in mindfulness. And people often say it's a tall order. But if we think about the opposite of all of these, what would you be like? You would be a judgmental, impatient, rejecting, grasping, striving, suspicious know-it-all, right? Maybe people like that. They're not the happiest, right? It's basically a recipe for stress. So these are some of the attitudes to hold in mind as we're learning a mindfulness practice. Now, there's also many myths and misunderstandings about mindfulness and meditation in general. So it's useful to specifically talk about what it's not. So it's not the same as just relaxation. You may feel relaxed when you're practicing it, but that's not the objective, is just to sort of calm down and relax. It's not a form of kind of hypnosis or someone trying to sort of change the way your mind works from the outside. And it's actually not specifically prayer or a religious practice. Now, the thing about the way we train ourselves in mindfulness is that it's very secular, it's very sort of generic. And so most people who have a traditional spiritual practice or religious practice or a prayer practice, they can take the mindfulness and incorporate it in whatever their religious practice might already be. So it can be adapted to fit within different traditions. So I see people from all sorts of backgrounds, from atheists to Catholics to Muslims to indigenous people, and they're all able to take this attention training of mindfulness and fit it in with whatever their practice already is. And now there's also this misconception that, when you practice meditation or mindfulness, you're all blissful and your mind goes blank and everything's wonderful, right? You clear your mind of all thoughts and it's peaceful and calm. That's not often, well, sometimes that's the case, but that's not the objective. And that's not always the case, because mindfulness is just about being present and accepting and aware of whatever your experience is. So we can be mindful of being angry. We can be mindful of being fearful or sad. It's just an embracing or an acceptance and an awareness of whatever our emotional experience might be. And familiarizing ourselves with how that changes over time and how it influences our overall experience of life. So it's really about gaining insight into how we cause ourselves suffering and how we can alleviate it to some extent. So where does mindfulness fit therapeutically? So if there are some clinicians or psychologists in the audience, you might be thinking about this. If this is not your background, don't worry too much about it. But when we talk about the sort of evolution of psychological therapies, we can go back to psychodynamic therapy, in the late 1800s with Freud and Jung. And then there was a behavioral revolution. This was Skinner and Pavlov, where they said, no, it's not about these deep unconscious things. It's just about behavior. And they really took it, to the opposite extreme. So then it came to the middle, where in the 1950s, people like Beck and Ellis came up with cognitive behavior therapy or cognitive behavioral theories, where, okay, it's also thoughts, right? So it's not these sort of deep psychological things only. It's not only behavior, it's also thoughts are important. And then there was a bit of pushback to that in this humanistic therapies in the 60s, that it's not just thoughts, it's like feelings, it's kindness, right? It's this unconditional positive regard. The therapeutic relationship is important. That was the humanistic approach. So now, starting, I'd say, about the 1980s, 1990s, we have what is known as third wave therapies. So these are the acceptance-based therapies, like mindfulness-based interventions. We call them broadly, or mindfulness-based programs, as well as acceptance and commitment therapy. These are third wave therapies because they take cognitive behavior, humanistic approaches, but add in this element of acceptance, which is a really core part of how we deal with difficult experiences and difficult emotions. So why is mindfulness so useful in general, but also for people with cancer? Because the only certainty in life is change. And many of you, of course, right? But sometimes we don't think about it that way. We want things to be the way we like them. And so we push back against change. So the unwillingness to acknowledge and act upon this reality is, in many cases, the root cause of suffering. So mindfulness is one way that we can face and accept the inevitability of change and learn to go with the flow and to go with uncertainty and not fight against it, because that really does cause a lot of suffering. So we like to use poetry in our program. This is one poem from Thoreau. He says, "I went to the woods because I wished to live deliberately, to front only the essential facts of life, and see if I could not learn what it had to teach, and not when I came to die, discover that I had not lived." So that's this idea of walking through your life on autopilot, right? Your mind's always down the road in the future, and you kind of miss the only time you really actually do have, which is the present moment. And so we want to keep that front of mind when we're thinking about learning mindfulness and training people in mindfulness. So here's where we can practice it just a little. All we're going to do actually is just pay attention, right? Because mindfulness is just directing our attention on purpose in a kind way. So if you want to just look at the nice picture here, or you can close your eyes, let's just all give it a try just for a few minutes. So if you're sitting down, perhaps place your feet flat on the floor. You might want to sort of just straighten up your spine a little bit so you can breathe easily. And if you are comfortable, take one hand and place it over your belly. And don't judge the size of your belly if you're prone to that. And one hand on your chest. And I'm just going to ask you to pay attention to your breath, right? So don't change it. Don't judge it. Let's just notice what's already there. That's always there with you is your breath. So if you want to shut your eyes, that's fine. If not, just allow your gaze to sort of soften. And then just keep breathing and notice as you breathe in that you're breathing in, and notice where you feel movement in your body. So the hands can sort of help you hone in on that. Do you feel as you breathe in, your top hand is moving, or the bottom one, or maybe a little of both? And then as you breathe out, the same thing, noticing where you feel the movement. And notice if the judging mind tells you you should be breathing a certain way, and let that go. And be like a breath detective. What can you notice here? So pay attention to the length of both the in and the out part of the breath. So is one perhaps longer than the other? Does the breath flow smoothly, or are there pauses or stillness or jerkiness here and there? What happens after the in breath? How does it transition to the out breath? And as you're doing this, your mind probably has already wandered, right? That's the nature of mind, that monkey mind, jumping from branch to branch or thought to thought. And that's totally normal. Don't get mad at yourself, but draw it back in. Say, oh, come here, kindly. Take the breath, draw it, or take the attention, the awareness, draw it back to the breath. So continuing to note in and out of the breath. And you may notice other things about your body or your mind. Maybe there's some tension in the face or neck, or your shoulders are scrunched up. If you notice that, you can choose to adapt or release tension. You don't have to. You may even be able to feel your heartbeat, your stomach working. And again, if your mind drifts, gently bring it back, just noticing in as you breathe in. Notice where you feel that movement in the top or bottom hand, and as you breathe out, feel them perhaps dropping down. So just take a few more breaths here. You may also notice that, again, don't try and change it, but just paying attention to your breath sometimes results in a change just in and of itself. Now let's open the eyes, lower your hands once again. And so normally here I would ask people, what did you notice about your breath? If you want to jot a word or two into the Q&A or the chat on the platform, you can. Some people say they noticed more movement in the top hand or the bottom hand. So you might not note that if the movement was more in the top part of the chest, or if it was down in the belly. And was it smooth? Did it change? How did you feel throughout the exercise? Did you notice your mind wandering? Did you remember the mindful attitudes and apply some kindness and just awareness to the experience? So that's just a very brief introductory practice. If we have time at the end, we may do some more. And I'm going to move on and introduce you to a book that I've written with my colleague, Shauna Shapiro, called The Art and Science of Mindfulness: Integrating Mindfulness and Psychology into Psychology in the Healthcare Professions. So this is a bit of a textbook for healthcare professionals that's out in its second edition. And here is a good sort of introduction on theories of mindfulness, what it means to be mindful as a therapist, different mindfulness-based therapies that are available, and how you can use mindfulness to influence your therapy, even if you're not actually training people in these kinds of exercises. So that's available. And now I'll turn to mindfulness-based stress reduction. So this is a program that was developed by a fellow named John Kabat-Zinn, who's very well known worldwide for this program. And he started it in the late 1970s in Worcester, Massachusetts, in the eastern part of the United States. And it was meant to help people who were kind of falling through the cracks in the medical system. Maybe they had chronic pain, maybe they had anxiety, all kinds of different medical conditions. And he combined in an 8-week structured program, stress reduction techniques that were fairly mainstream from cognitive behavior therapy, but with the mindfulness techniques. And he had spent time training in meditation across Asia and things like that, and thought that these techniques might really help people. So he developed this program and wrote this book, Full Catastrophe Living. It's called Using the Wisdom of Your Body and Mind to Face Stress, Pain, and Illness. And it first came out in 1990. It's been through many editions. It's kind of a classic now, highly recommend it. And so this mindfulness-based stress reduction, MBSR program, has become very popular. There's training centers all over the world, and it's been applied to many different psychological and medical conditions. And you can find all that research on this website called GoAMRA. So AMRA is the American Mindfulness Research Association. And it actually summarizes all the research on mindfulness that's been done over the years. So I often ask people in terms of the research, how much do you think is actually out there? So this is a graph that shows a search through all the scientific literature. So the Web of Science is a scientific peer review platform where they search for the term mindfulness in academic journal title articles. So if you search for mindfulness on Google, you'll get hundreds of thousands of hits. This is the scientific studies that have been published, in the mainstream peer-reviewed journals with mindfulness in the title. So often I would ask audiences, how many do you think came out last year of this nature? And the guesses might range from 50 to 1,000. And these are the actual numbers. So what you'll see here across the bottom is the years, and it shows you an increase in the numbers of mindfulness articles year by year. And really, the first article started way back in 1982, and it was mostly John Kabat-Zinn, a few things. And right around the year 2000, it started to uptick. So actually the year 2000 is the year we published our first article on mindfulness for people with cancer. And, I could follow all the mindfulness literature for 5 or so years. There's only 50 articles to read, but then it started going crazy. And the latest year, 2020, it is over 1,000. So there's no way now that anyone can keep up with all the scientific research that's going on in the area of mindfulness. And you might ask yourself, well, where, what is all this research about, right? I'll tell you in a second. And so I'll first introduce other what we call mindfulness-based interventions. There's so many adaptations now, right? It kind of blows your mind away. Some of these are mindfulness-based relapse prevention. That's for people dealing with substance abuse, smoking cessation, alcohol, drug abuse. There's mindfulness-based eating awareness training, or mindful eating, conscious living is sometimes called, for people for obesity, eating disorders. There's mindfulness-based art therapy, which combines doing art therapy, but in a mindfulness sort of way. Mindfulness-based childbirth and parenting programs. Mindful self-compassion is a big thing. Mindfulness at work, so it's really been applied in the workforce in many ways. And this is actually from a Center for Mindfulness Training through the University of California in San Diego. And they have all sorts of online training in different mindfulness-based programs. And it's a sea of acronyms here, but that's a number of them there. So what are the research areas? So really, this is just from a quick search of ongoing clinical trials in mindfulness. And so you'll see, you name it, there's a mindfulness trial, investigating whether or not it's helpful, right? So mental health, one of the first adaptations was called mindfulness-based cognitive therapy for preventing depression relapse. There's lots of research showing it's just as effective as maintenance antidepressant therapy in that context. Lots of applications to anxiety, post-traumatic stress, trauma, bipolar, down the list it goes, right? In physical health, again, many, many different conditions. And usually it's around treating symptoms and side effects related to that condition. Sometimes it's related to disease markers, like for example, in irritable bowel, mindfulness-based interventions actually decrease the symptoms related to that disorder, like constipation, diarrhea, bloating, gas, all that kind of stuff. So our area has been in cancer, and it's actually one of the most well-researched areas, but also there's lots of work in hypertension, cardiovascular disease. So we know that mindfulness training can decrease blood pressure, for example, help people with HIV and AIDS. Some studies show it helps control even the T cell counts, which are an important marker of immune strength in that condition. Right down to pain, there's quite a bit of work, arthritis, diabetes. Again, you kind of name it, people have tried using mindfulness-based applications. And then in healthy populations, there's lots of interest in whether it can affect inflammation or immune function. Within the cognitive realm, there's lots of research on attention training, if it can improve different aspects of attention and cognitive functioning. Looking at using mindfulness for seniors, wound healing, how does it help treat stress in different settings, infectious diseases, and then education. So there's another whole push for mindfulness in the schools. Starting, with little kids, right, preschool, kindergarten, and there's many, many different curricula and studies that have looked at that. So that kind of gives you a big overview. I'm going to hone in now on the work we've done with cancer patients, survivors, and families. So people might ask the question, and probably this group not as much, but why? Why would we use mindfulness in people with cancer? And I think the cartoon here with the spider illustrates one of the central features of the cancer experience. So my life's a mess, doc. You got to help me. I just seem to be spinning out of control, right? And that's fine if you're a spider, but it's not a very comfortable feeling if you're a person. So when we think about the illness experience, one of the central features is this loss of control. You kind of thought you had some say in the way your life was going to unfold, and then this cancer often comes out of nowhere, and you don't know what's going to happen next week, next year, next month. You sort of turn yourself over to the medical system, who tells you you're going to have surgery, you're going to have chemo, you're going to have this and that. And all of a sudden, you're feeling like you're sort of spinning out of control. There's that life threat, whether the prognosis is good or not. And when people hear cancer, they think, oh my God, my grandma died of cancer. It's terrible. And so they need to think a bit more closely about what if this means my life is going to be shortened. So everyone has a conceptual understanding that we're all going to die, but for most people, we don't think about it. It's sometime way down in the future. It's kind of vague and fuzzy. People diagnosed with cancer have to actually start talking about that and thinking about that, so it can provoke a lot of existential anxiety. And then loss of certainty, loss of routine. All of a sudden, you thought you'd work and retire and have whatever kind of life, right? But now you don't know. You may have to take time off your work. You may have to, reschedule everything. Like Chioma was saying, you might have to move to another center for weeks or months of treatment, and all that change in routine can be very stressful. And then there's all the symptoms: grief, fear, anger, depression are not uncommon. Shame, regret, you name it. And then symptoms of treatment and illness like pain and fatigue and sleeplessness can be very troublesome as well. And after treatment, no matter how good the prognosis, there's always a fear of recurrence, right? It's like, okay, every ache and pain, is this the cancer coming back? What does this mean? So there's always that fear. And then whenever you have checkups, sort of anxiety builds to the checkup, the test comes back, it goes down. So it's never really over. But it turns out that in the mindfulness approach, we teach skills in emotion regulation. So seeing the emotions, accepting them, attitudes of acceptance, non-attachment, self-compassion. I haven't mentioned yet, but it's a very important part of the program. All of these approaches that are part of a mindfulness-based program help cope in different ways with these elements of the illness experience. So our program we call Mindfulness-Based Cancer Recovery. It's based on that MBSR model. And the idea for this started in 1996 with my colleagues who were social workers and psychologists working with cancer patients, Michael Specka, Maureen Angan, and Eileen Goody. And they had personal yoga and meditation practices, themselves for many years, often from the 60s or whatever. And they got together and said, when we're not feeling good, we do our yoga or our meditation. Why don't we think about bringing that to our patients? So it wasn't based on any previous research or anything. But I came in 1997 and I knew John Kabat-Zinn and I had met him and I had practiced meditation with him. And I knew about the MBSR program that was fairly new at that time. And I said, well, this is great, you guys, someone's already done this, like maybe we could adapt it. And so we did that in 1998, and our program has been available freely. We have a public payer healthcare system in Canada. So it's open to cancer patients and family members free of charge. We do it in groups of 15 to 20 people, and usually we offer anywhere from 3 to 9 groups every year. And so over the years, we've been doing it for 20 odd years, there've been some 3 or so thousand people through. And we have this ongoing clinical program, and we embed our research studies within that. So some of the people in the program might be part of this or that research study. So over the years, we finally decided to put this all in print. And so Michael and I wrote this book called Mindfulness-Based Cancer Recovery, a step-by-step MBSR approach to help you cope with treatment and reclaim your life. And so this is meant to be for patients as a home study manual. We recognized pretty early on that very few people could actually come in person to our program, right? Even within our context, we're in one city and people had to come every week. And we really were very concerned at the beginning about expanding reach. And so the book was the first way to do that. And anyone can buy it. It's not that expensive. And it actually takes you week by week through the program. It has guided meditations included in there that people can use. So if you're interested in learning more, that's a good place. It has been translated into a whole stack of languages. This shows, I think, French, Dutch, Spanish, German, 2 different versions of Chinese, traditional and simple. And I think we just got a Vietnamese translation as well. And there might be an Arabic one. So it is available in many different languages. So what's the program all about? It's now a 9-week intervention, started as an 8-week intervention. It's now 2-hour classes actually. And so ideally, I think 8 weeks, 2 hours is what you're after. We meet weekly with 2 instructors typically, and it always follows the same format. So we have a discussion at the beginning, check in on homework. We do mindful yoga practice and meditation, and I'm going to tell you specifics about that in a bit. We give patients a booklet. It outlines the program. It has a reading list in it, and we give them materials so they can practice daily at home. So it used to be CDs. Now it's a link to some MP3 files they can use. So they keep a homework log of time spent in meditation. They're assigned to do 30 to 45 minutes of practice every single day throughout the program. And that's how you actually do the practice, right? Like I said, learn the skill, you have to do it. And there's a 6-hour silent retreat near the end of the program between weeks 6 and 7 usually. And so the overarching theme of the program is mindfulness, and everything we do are ways to train yourself in mindfulness skills. We teach them how to do bodily relaxation through abdominal breathing. We talk about the physiology of that. We also incorporate gentle yoga. So half of the practices we do are what we would call mindful movement or gentle yoga. So it's not an athletic event, where you're wrapping your leg around your head. It's mindful movement. It's very gentle, simple movements. I'll talk a bit more about that, I think, in a minute too. There's an emphasis and a bit of teaching around how the mind and body are connected. Of course they are, right? It's ridiculous to think otherwise, but how that plays out with our emotions and our thoughts and our feelings, we work with that. We use visualization and imagery to some extent. We focus on cognitive coping strategies as well. So this is around the stories we tell ourselves and how they can sort of influence our experience. And there's that element of personal empowerment. So giving back a bit of a sense of control. Like here, I can't control a lot of things that are going on, but here are things I can do anytime I want that are going to make me feel better often or help me get in touch with what I'm feeling. And because we do it in a group, traditionally, there's an element of social support. And I know patients really appreciate that. Even on Zoom, we're doing our groups on Zoom now. They still have a sense of, not being alone in the experience. So there's a different theme each week in the program. We start with an introduction to mindfulness. What is it? What are the attitudes? We spend some time talking about what we call mind, body, wisdom, and healing, and this responding to stress versus automatically reacting to stress, how we can use breathing to balance out our nervous system, the mindful coping piece, and then we talk about using imagery to cultivate beneficial states of heart and mind. Oh, and by the way, speaking of imagery, this is Mount Rundle from Banff, which is 20 minutes from my house. So this is where I'm at. And then in the 7th session, we talk about sort of deepening the practice, expanding it to other sort of targets, and then how do we continue? How do we move into the world after we've been establishing this practice, how do we sort of keep it going? So there's many different types of practices we do in an MBCR program. On the right, upper right, is what we call body scan. So it looks like they're having a nap. They're not, they're actually awake, and they're taking their attention systematically and slowly through the body, starting either at the toes or the head and very slowly moving up. And so it's a way to do a couple of things, really, is to learn to direct our attention where we want it to go. And that's one of the central skills of mindfulness, is this attention training, right? So our mind just jumps around, and often we don't really have much say in where it goes. So we're training ourselves, okay, we're going to go to the toe, and we're also connecting with the body as we do that, right? Learning to really feel what's there, whether it's tense or relaxed or cold or hot or whatever it is. So the body scan trains us in that. Sitting meditation is one of the core practices. So this fellow's sitting on a chair. And again, you don't have to sit on the floor cross-legged, is kind of the stereotype. A lot of people, especially in North America, they're not used to sitting on the floor, and it can be uncomfortable. So often we just do sitting in the chair. Walking meditation. So that's a traditional practice where traditionally you sort of slow down the walking and pay close attention to, the sensations of walking, being in the body and all that. Open awareness meditation is where we sort of open it up a little bit more, outside of just maybe the breath, and more awareness of all elements of experience. I mentioned we use imagery. So often where I live, we use a mountain imagery, or you can use a lake or any other kind of image to sort of enhance qualities that we want to emphasize in the practice. And then loving kindness is sort of comes from the emphasis on self-compassion and compassion for others. And maybe at the end, if I have time, I'll do a loving kindness practice, because that'd probably be quite nice. So I mentioned the yoga, and there tends to be more emphasis on the meditation, the sitting meditation in mindfulness-based interventions. But for people with cancer, I really think the movement, and it doesn't have to be yoga. It could even be like traditional movement practices. We've used, more like sort of Qigong or Tai Chi based things, but this connection with the body, and also in some ways strengthening, our awareness of the body, but also strengthening the muscles and the joints through the yoga, I think is really important, especially for people who've been through treatment, maybe surgery. They need to reconnect and refriend or refamiliarize themselves with the physical body. So I did say I'd talk a bit about research. I'll try not to spend too much time on this, but it is, I think, interesting. So we started our research with when we first started our program, and this was like, again, 1998, our very first study. We were just starting the program. Nobody had really done this anywhere. So we took anybody who showed up at the door. We had 89 people show up. They could have any kind of cancer. They could be on or off treatment. And we just randomly assigned them to either do the program immediately. So we took a baseline assessment of everybody. Half of the group did the program. The other half waited. They're all reassessed. And then we can compare, how did the people who take the program change compared to the people who didn't? And then the people who were waiting, they later got the program. And so it was the first study ever to be published on mindfulness in cancer patients. And we looked at symptoms of stress and mood disturbance, were the primary outcomes we were looking at. And sure enough, they improved, and quite a lot. And I'll show you in a second. And then we followed everybody after they'd all done their programs for 6 months, and the improvements were maintained over that time period. So this is just the people in the study. So they had all different stages of cancer, early stage 1 and 2, but also more advanced stage 3 and metastatic patients. And this is the outcome we use. So the blue is the mindfulness group. You can see higher scores or worse, more mood disturbance, right? So at the beginning, this is quite a high level of mood disturbance in both groups, but you can see after the program here in the blue, the mood disturbance went way down for the people in the mindfulness group. And this is just the magnitude of change, the decrease here. And it turned out to be a very large effect size. And we looked at subscales on this measure, and we could see that a lot of the change was happening in anxiety, depression, anger. They felt more vigorous, and less improvement in symptoms of fatigue and mental confusion. So that really gave us a taste for the possibilities with this type of intervention. The other outcome we looked at was symptoms of stress, and it's the same pattern. So at the beginning, both groups quite high stress. After the one group had done the intervention, their stress went down a lot more than the people who were just waiting. These are some of the subscales. So habitual patterns of stress, that's kind of behavioral patterns like, grinding your teeth, overeating, smoking. Those things decreased in muscle tension, cardiovascular symptoms of stress like a racing heart, breathing quickly, And then symptoms of irritability and anxiety as well decreased. So that got us started. And now I'm going to kind of like fast forward through 15, 20 years of research and summarize it for you. So we started with stress and mood, and we saw improvements in those kind of symptomatologies, but then we also looked at other symptoms and side effects that were really bothering people living with cancer. So it turns out, yes, it can improve sleep quality, sleep duration, decrease feelings of fatigue. And then we looked at kind of mechanisms, like how is it improving these things? And sure enough, people were ruminating less about the past. They were worrying less about the future. Now, our program's also open to partners and caregivers. So we looked at them too, and they also were improving. And then we started to hear from participants that not only were their symptoms getting better, but they were actually thriving. They were, improving beyond just symptom reduction. And so we started looking at things like, well, quality of life is pretty standard, but spirituality and post-traumatic growth. And these are concepts around feeling connected. Spirituality is not the same as going to church, what we would call religiosity. But spirituality is more feeling connected with something larger than yourself, feeling a sense of meaning and purpose in your life, feeling a sense of peace. And post-traumatic growth is sort of similar. It's this idea that a traumatic experience like cancer can be a bit of a catalyst, a motivator to look at how you're living your life, right? And seeing, are you living in truth or in concordance? Are you being authentic with your values, right? Are you, again, feeling a sense of meaning and purpose? And so people told us that these things were changing for them too. It was really helping them to take the time to really connect deeply with what was meaningful for them. And they reported, also in tandem with that, feeling overall more present, more mindful, more in the present moment, more engaged with their lives. So that was really interesting to see. And now I have a background in what's called psychoneuroendocrinology or immunology, and that's looking at the scientific study of how our psyche, right, our thoughts and our feelings are connected with our nervous system. And there's different measures of that, fight or flight reactivity, and then our endocrine and our immune systems as well. So to measure those kind of things, we take blood samples, we take saliva samples. We've also looked at blood pressure as the first one on there. And sure enough, right, people who had elevated blood pressure, just systematically over 8 weeks of the study, it would decrease to a normal range. The cortisol is a marker of stress reactivity, a hormonal marker of adrenal secretion of stress hormones. And those patterns change too. We looked at inflammation in the immune system by measuring cytokines. And sure enough, there's less inflammation. And we've even looked at the level of the DNA through blood samples and looked at the chromosomes and telomeres, or the ends of the chromosomes that are related to cell aging. And there's a signal, I guess, preliminary research. We were the first people to look at that potentially these kind of programs slow that cellular aging as well. That's a risk factor for cancer and other diseases. So lots of research. You can find it all on my website, lindacarlson.ca. Just go in there, there's publications. If you want to view and download any of them, you just need a password, which is publications. So go wild. Now, we did a lot of that work early on, and we've also done a lot of clinical trials. And I'm not going to go through them all. You'll thank me for that. But I'm going to summarize a number of them here. And I like to give them catchy names, right? So MASTER, and these are finished ones. You can learn about them on the website. We did acute stress test reactivity and recovery. So we brought people into the lab. We stressed them out. We hooked them up to a bunch of machines. We looked at their blood pressure and all this kind of stuff to see if training in mindfulness could make them less reactive to stress. It didn't very much, but that's another story. The next one we called Mind in Motion. This was where we looked at mechanisms and mediators of change. So we measured people at the beginning, halfway through, and at the end. And then we modeled all these things, how they changed, what changed early, what changed late. That was interesting. We targeted sleep, comparing the mindfulness program to the gold standard treatment for insomnia, which is called cognitive behavior therapy for insomnia, and found the mindfulness could be just as good. It wasn't as quick, but it caught up after a few months. People were improving in sleep the same amount. In mindset, we started comparing our mindfulness not to just wait list or usual care, because almost anything's better than nothing, right? But comparing to other therapies. So supportive expressive therapies like a therapy group. And we compared the two in the mindset study. And I'm going to tell you about the ECOM study because I think it might be of interest to this group, some of the other adaptations we've made to reach people not in person, so online mindfulness. And then some of our ongoing studies, we have something called the MATCH study, which is comparing the mindfulness program to a Tai Chi Qigong program. One Mind is online mindfulness, so I'm going to talk about that a little bit more. And Seamless is a mindfulness app that we've developed. So just a bit on some of these adaptations for wider implementation. So as we know, there's many barriers to face-to-face, so F2F participation. And largely geography is one of them, getting people wherever you're offering the program. The time it takes to do that, right, is much more time traveling and back and forth and getting there. And the cost of that, right, of transportation and parking, childcare, salary, time off work. And also the symptoms and side effects themselves, right? If people have fatigue or extreme pain, it's going to be very difficult for them to put in all the extra effort to get there in person. Many people are immunosuppressed during treatments and are not meant to be around groups of people. Oh, and now, of course, COVID-19 restrictions. So we have turned to digital health interventions and are evaluating those as potential ways to help expand the reach of the program. So we did the ECOM study, which I think I'm going to tell you more about in a second. And this was way back in 2012, almost 10 years ago, before everybody was Zoomified. And we did an online interactive group like this. And then we made a partnership with a company called emindful.com to offer that to patients. And we're doing a study during chemotherapy, One Mind. And I think I might have another slide on that. Then we developed with an app company, something called the Mindfulness-Based Cancer Survivorship Journey app. And I'll tell you a bit more about that. And right now, we're actually doing a virtual reality guided meditation study. We're just starting for people with chronic pain. And again, we've partnered with a virtual reality company to develop the experience. And so we're just getting started with that. There we go. Yeah, so the ECOM study. Again, this was way back, I think 2012 we started it, or maybe even 2011. And we thought, okay, can we reach people who can't come in person, right? So Alberta's my province where I live is very big and spread out. And there's many, many people who could never come to our center in Calgary, a tertiary cancer center. So we took rural and remote cancer patients and we just wanted to see if they would do it and if they would like it and if they would benefit. This is early days, right? So we were looking at feasibility. And then we had the kind of same questionnaires we used in other studies like mood, stress, mindfulness, spirituality, post-traumatic growth. And so this is what it looked like. It was a platform where we had an instructor. That's the guy in the upper right-hand corner. He was experienced in providing online mindfulness already. And you could, see the other participants down at the bottom here if he would show them, and then you could share sort of teaching materials. And when he did the meditations, he would put it on full screen like that. So it was live, real-time, interactive, like a Zoom meeting when everyone would come together, and it was meant to simulate the in-person experience as much as we could. And people liked it. Most were satisfied, but a larger group were positively surprised, saying it exceeded their expectations. So it either met or exceeded everyone's expectations. Almost everyone would recommend it. And, the reservation was just make sure you can have your setup in your house where you can see the computer and do your practice and that kind of thing. And these are some of the outcomes on the questionnaires. And so we had a waitlist control group again. And so the people in the program are the dark lines. And what you're seeing here is that the total mood disturbance decreased for people in the online program more than those waiting. And this is the total stress score. And then other things like mindfulness. Oh, this is spirituality. So not as big an effect, but again, the spirituality improved more for the people in the program. And mindfulness also improved. So people, said they enjoyed it. Having the online access was a huge benefit. I could conserve my energy for the course and content. So this person was already in treatment, and they found it easier on non-course days to keep up with the program because they were already set up in their home environment. There's another person who was doing radiation therapy. They would do it every day during the treatment as they lay on the treatment table and just be aware of the surroundings. So that was good time. And, we were wondering whether people would engage online. And this person, actually, we're also trying to get more men in the program because often it's like 70, 80% women. And we did get more men. And this is one of them. He said he was hesitant. He's not a touchy-feely person. I had reservations. but he had very little actual experience. And so we really enjoyed the sessions, and it was a highlight of the week in many ways. So that was kind of neat to hear about. And then another good thing about being online for people who live in really small communities, there tends to be gossip or chit chat. And this person said, it was nice that we were unlikely to run into each other was a positive thing. So I didn't have to worry about someone in the group talking to other people, that I know or work with, about me or about my cancer, right? And this person said, the online format worked. It held just the right amount of contact and closeness. And we were wondering about that, could people sort of make the same bonds and connections with the other participants? And it's not exactly the same. And, we've been doing it now. Everyone's been doing it more on Zoom, so there's a lot more experience with it. But this was the first sort of study of that nature. And, we did find that people felt they could connect. And so that's when we formed a partnership with this company, eMindful, back in 2015. And now they offer the program. So they have a number of different programs that you can take online. There's a small fee for it, but we wrote a program up, we wrote a manual, we trained their facilitators in our program. So they've got the space cancer recovery available online for anybody through eMindful. We're studying that program now to see most of the studies in mindfulness have been post-treatment with cancer survivors who are kind of done going through, the chemo or radiation or surgery. And we show that at that time, if people still have symptoms and side effects, it can be helpful. But the idea was, well, why don't we do it sooner, right, before things get bad? And maybe we can prevent or diminish or delay the onset of these chemotherapy-related side effects that are quite troublesome. And so that's what we're doing right now is we're getting people before they start chemotherapy. Half of them are doing it during chemotherapy, and the other half are doing it 6 months later when typically they're done chemotherapy. And so it's the same as the eMindful program, which are shorter sessions, but more sessions. So 12 55-minute sessions. And they do daily home practice. They're supposed to do it during their chemotherapy infusion sessions. And mostly we're targeting those chemotherapy-related side effects like fatigue, nausea, vomiting, sleep problems, stress, mood, as well as some cognitive function. So it's been going on for a while. It's been disrupted a bit because of COVID, but we're still plugging away at that. Another development is the app I talked about. So we know that people are using apps like crazy. It's an innovative delivery method. It's popular, overcomes almost all the barriers to in-person programs, as well as online synchronized programs, because you can do it on your own anytime, right? But what are the drawbacks? We don't know. There's mindfulness apps everywhere, and I've just listed Headspace and Calm are a couple of popular ones, but they've largely not been tested, and none are specific for people with cancer. So we thought, why don't we take our MBCR program and turn it somehow into an app? So we partnered with this app company called Mobio Interactive, and they have their developers, and they already had an app. It's called Am Mindfulness. It already existed. And it was a nice app. It had all these journey programs. It had already been tested. And so they suggested to us that we could create a journey based on our program that would be within the app, and we'd still have all the features that are there. So there's like a whole audio library of guided mindfulness. They have other activities. There's sort of stress self-assessments. So we created the Seamless study to do that, and we did it in phases where we developed the program to be delivered on the app. And then we did a little sort of pilot feasibility study where we looked at whether we could recruit people who would test it out for us. So we did some user acceptance testing, and then we also looked at questionnaires for people who went through the program. So we took our program here, we turned it into these 5 units. So that there was a teaching component for each of the units, what is mindfulness, the attitude, stress response, sort of key core teaching elements. And then there was a guided meditation and an exercise that went with each one. And we turned all that over to the app developers, and they turned it into a journey. It's called the Mindfulness-Based Cancer Survivorship Journey. And so it's 27 audio tracks. It's something like 250 minutes in total, and they're locked. So you have to go through it in order. And we decided to test it out over 4 weeks. And so the phase 3 was our user acceptance testing of the app. So phase 2 was where we recruited people, and actually it was quite easy we just sent invitation letters to people in our cancer registry saying, do you want to test out this app? We recruited 80 some odd people. We used the first group as user testers. So we were going to do a traditional randomized controlled pilot study, but the first group of people, the immediate group who were supposed to go through, the app wasn't ready. It wasn't good enough. So many people dropped out in frustration. They had technical problems. These are older people often. You know, some of them really hadn't used smartphones very much, so they didn't even have an Apple ID or an account, you know, in the App Store. So they have to download the app. You know, they had to get a 1-year free trial validated. They had to find the journey. They had difficulties, and so that's a good lesson to be learned. You can't just hand people an app and expect them to figure it out. So they needed help with an app navigator and an instruction manual. They wanted an in-person, a real-time person they could text. And so we came up with a strategy where if they had any problems, there was a text messaging platform, because text messaging is a lot easier, and we could help them and get on the phone with them and walk them through it. So when they were finally able to do it, you know, we did some interviews and had some quotes here. So, you know, people said, I actually felt the mindfulness for cancer study was specific for me, and that it was helping me get through my post-cancer treatments. It's been a very, very rough journey. I actually enjoyed listening to the ones where there was 2 people talking. So we had gone into a studio, Michael and I, and recorded our teaching. And then they turned it into these sort of elements of, you know, teaching through discussion. So there's 2 people talking, the different tones. I felt like it was an actual meditation. They're actually there with me. And also here, person saying, I found the journey forced me to block out the world and say, okay, this moment is mine right now. I'm going to enjoy this moment just for myself. So it seemed that the app was still engaging people. And then we had the second group, who was supposed to be the wait list, fill out questionnaires. So these are a whole range of different things we looked at. We looked at stress, fear of cancer recurrence, you know, sort of mechanisms of change like mindfulness and rumination, and experiential avoidance is the tendency to avoid experience rather than face it and accept it. We looked at anxiety, depression, fatigue, and then we had a bunch of app-based outcomes. So we could get data from the app around how engaged people were, how much time they spent on it. And also there is measures in the app around mood and stress. So we have that data to explore as well. We haven't looked at that data, but in terms of the questionnaires, so we had 39 of the people, you know, after we fixed things up, most of them were able to complete the journey. They spent 40 visits to the app, about 240 minutes. And we did see significant improvements on a number of the outcomes. So stress, fear of cancer recurrence, anxiety, and mindfulness were the main ones we saw changing. So there's a map of Canada. Oh, I live right here by the red line, kind of there. So our next step with this is that we are trying to get funding for a Canada-wide trial, which would be about 345 cancer survivors who would use the app, you know, and again, just a waitlist controlled version, to see if just using that app would help to improve some of these symptoms. All right, so here's where we pause for a moment. I think we got about 20 minutes left, so I'm not going to do a mindfulness exercise because I want to go through the curriculum with you guys in a bit more detail. But I will do that fairly rapidly, and then we can either have time for questions or maybe we'll finish with a loving kindness meditation. So I'm actually going to take you week by week through this, but I don't think I'll spend a ton of time. Basically, what we're seeing here is how the program is set up. So in our first session, we spend some time getting to know everybody in the group, talking about the group principles, you know, confidentiality and those kind of things, and really dwelling on the question of what is mindfulness. We do a similar breathing exercise, a longer version of what we just did earlier. And the main practice is the body scan, which I mentioned, right? So for the first couple of weeks, the meditation practice is the body scan. People find it a bit easier than launching right into sort of just awareness of breath or sitting meditation, because the body's tangible and you're moving slowly through all the different body parts. And in the first week, we may do introduction to yoga. And every week there's homework practice. So in their booklet, there's a log, you know, you're supposed to keep track of how much time you spend each day and any sort of comments about your practice. So in the second week, we get into more detail on the different attitudes. So every week after the first week starts with a discussion of home practice. And in the early days, we spend a lot more time on this because really what we're trying to do is just establish a regular practice early on. And that's the key objective. It's not the nature, you know, how good the quote unquote good the practice is. It's just actually getting them to do it. And so a lot of time spending on discussing any barriers to home practice, helping people implement this in their lives. We do something famous, raisin exercise, where we eat a raisin mindfully. So that introduces some, we're moving from like sort of formal exercises to more informal mindfulness throughout the day with things people can do. So we get them to think about eating meals more mindfully, spend a lot of time on the attitudes that day. And another way to move it into the world is something called a pleasant events log, where people keep track of small pleasant things that might happen, you know, unexpected phone call from a friend or something. And just breaking down how that felt emotionally, how it felt in the body, you know, and really trying to increase awareness of these little things throughout the day. We work through, so the yoga practice starts with lying postures. And again, they're very gentle. And the focus is on awareness of sensation in the body, of working with the breath. So all the movements are coordinated with the breathing. And we introduce the sitting meditation in week 2 or 3. And sitting meditation begins with focused awareness meditation, where we're focusing our attention on the breath. And as the mind wanders, we're just coming back. And this is training people in, you know, what you might call like a laser beam kind of focus, because until we have some capacity to direct attention where we want it to go, you can't really do any of the other exercises if your mind's just all over the place. And so people do find over the weeks that capacity to pay attention, to focus, improves with practice. So we start again every week with discussion of home practice. In week 3, we're talking all about the mind-body connection. There's a discussion of symptoms of stress. Actually, I have some details of that in a second. The distinction between reacting automatically to stress and responding more mindfully. And then we move into unpleasant events. So again, paying attention to little things that happen that might be irritating or upsetting, and how that affects what's happening, our thoughts, our feelings, our bodily sensations, right? And we continue with the yoga postures and sitting meditation. So this is an example of the symptoms of stress checklist we go through with people. And before we show them, and I probably should have done this with you, you know, I ask people, how do you know when you're experiencing stress? Like, how does it feel in your body? You know, what happens with your emotions or your behaviors? So, and then we break it down into these different dimensions and go through the checklist. So there's the physical symptoms, and, you know, people bring these up, right? Oh, I get headaches, or I get tense, you know, tension in my neck. I can feel my sweaty palms, or my stomach's upset. And then there's behavioral symptoms, you know, like teeth grinding, drinking too much alcohol, compulsive eating, those kind of things. And so people are encouraged to, as we go through, to check off the ones that might kind of be their red flags, right? So we're trying to get people to develop a stress profile, a characteristic way that they can be alerted that something's going on and that maybe they need to pay attention, right? So emotional symptoms like crying, nervousness, anger, you know, feeling overwhelmed. Cognitive symptoms like forgetfulness, memory loss, indecisiveness, you know, that sort of mental fog that often makes the brain fog they're experiencing from their treatments even worse, right? When you add stress on that. And how it can affect your relationships. So usually either lashing out or climbing up, right? And spiritual symptoms like loss of meaning and purpose, feeling, you know, doubt or cynicism or those kind of things. So then week 4, the focus is on balance in the nervous system. And so we spend a lot of time talking about the sympathetic nervous system versus the parasympathetic nervous system, and how breathing can affect those things and the balance. We teach them these mini mindfulness breathing exercises, which are very short. Actually, we might do that in a second if we have time. So much to do, right? That people can do in a short period of time anywhere in their lives that will help balance out their level of sort of energy versus relaxation in your nervous system. And we have a specific sleep exercise, and we continue each week with the yoga postures and the different meditation practices. Yeah, so these are some of the breathing exercises. Let's do a couple of them quickly. So these are balanced breathing exercises, and I often have a visualization that goes with them. So this one's riding the wave of breath. And the idea here is that we sit upright and we sort of allow our belly to relax, and we're going to switch to a fairly deep breath, and we're going to add the count. So as you breathe in, you count up 1, 2, 3, 4. And then as you breathe out very smoothly, 4, 3, 2, 1, and you imagine your breath like a wave. So you try it as we go through. And so you may notice just doing that a few breaths, how it allows the breath to become even and deep and smooth. And it can help to decrease if you're feeling anxious or stressed and kind of balance out the breath. Another one we do is called square breathing. So here that you add in a pause. So you might breathe out for say 4 and then pause or hold your breath with your lungs empty for 2 or 4. And then breathe in for 4 and the same thing, hold or pause at the top. So I don't think we have time to practice them all. This one's very popular, the relaxing triangle breath. So here we're emphasizing the exhalation, and part of the teaching in this class is that the exhale is associated with relaxation or parasympathetic nervous system dominance, and the inhale is associated with energizing or the sympathetic nervous system. So if you want to relax, you emphasize the out breath, right? If you think about it, when you're stressed, it's more these sort of short in breaths, and then when you want to relax, you kind of go a big deep out breath. So this relaxing triangle, you're basically breathing in for 4, directly out for 4, and then you're pausing just at the bottom, and maybe try that a couple of breaths. And you can close your eyes and just visualize that triangle. Or you can look at it directly. So let's move on from that to what we call the invigorating triangle or the upside down triangle. And so this is the opposite idea, right? So the emphasis or sort of 2/3 of the breath is on the in breath, right? So it's more invigorating. So you would breathe out for 4, in for 4, and then pause or hold at the top. And if you try that, you'll probably find you can feel your heart accelerating a little bit during the pause. Then we do mindful coping. And really what's new here is this discussion. It comes straight from CBT, but with a mindfulness twist about challenging our assumptions and the stories we tell ourselves. And this idea, I think I have another slide. And we also introduce a walking meditation. Yeah, so this idea that there's nothing either good or bad, but thinking makes it so. I mean, that's an extreme sort of form of this idea, but it's not necessarily what happens in the world that determines our reaction, right? It's how we make sense of it, how we interpret it, the story we tell ourselves. So we give an example, a simple thing of, your friend is walking by in the street, so maybe on the other side of the road, and you look over at them, you think they're going to say hi or greet you or something, but they turn and walk away, right? So that's the life event, the thing that happens. And then you ask people, well, how did that make you feel? Right. And so the answers are anywhere from hurt, rejected, angry to, relieved or not concerned. And the thing that determines the different range of feelings is our thought or our interpretation or the story we tell ourselves about this, right? Oh, she saw me and she purposefully avoided me. She's mad at me. What did I do wrong? Right. Or I wonder if everyone's mad at me or, are they avoiding me because I have cancer? Right. So, or the thought or interpretation could be, oh, thank goodness I didn't want to talk to anyone. Or maybe she just didn't see me, I'll check with her later. So it's really the thought or the interpretation that determines the feeling. So we talk about that a little bit. Then in week 6, we talk more about cultivating beneficial states of heart and mind. And one way we do that is the use of imagery. So the mountain or the lake image helps people to focus in on develop qualities that are mountain-like or lake-like. So mountain-like is like being stable and rooted and massive and seeing, the big picture, right? So we sort of use that imagery to develop the qualities. And we do loving kindness meditation, which is a specific approach to help develop feelings of compassion for yourself and others. And we continue with the yoga postures and preparation for the Saturday retreat. So the loving kindness practice is an ancient practice. It's traditionally called metta. And it aims to uncover and nurture specific beneficial qualities that support well-being. So the way the loving kindness works is that you can start with another person or with yourself. But the idea is to cultivate wishes for your own well-being. And then you slowly move it out to your loved ones and your maybe family or your acquaintances or your town or your village and, broadly expand to sort of everybody. So more distant friends, strangers, even your enemies is a little more challenging, and finally all living beings. So that's how the loving kindness practice goes. And then as we move through the program, we get into deepening and expanding. So we will have had the Saturday retreat by then, which is all just practice time in silence. It's guided by the leader, but the participants are doing the practice in silence. Then we move on from more focused attentional practices to bare or choiceless awareness meditation, a little more advanced yoga practices, and we do some of this bare awareness sitting as we get into week 7 and 8. And then our final week, either 8 or 9, depending on how you're doing it, is, okay, let's look back, right? A couple of months ago, what brought you here? What were you hoping for? And where are you at now? So it's very interesting. It's always really fun to have people reflect back. Sometimes they got what they wanted, or maybe they went in a totally different direction, and maybe they realize it's just the start. And that's really an emphasis we place. This is just the beginning. It's the iceberg. So how are you going to continue your journey with mindfulness? So we have people share their future plans, and we finish with a loving kindness meditation, a closing circle. Now, I know I'm running out of time here, actually. So I do have a lot of stuff on instructor training. Now, I put this in here. So what we usually recommend for people who want to be MBCR instructors is to do your MBSR instructor training first, because it's available everywhere. There's tons of it all around the world, and I imagine through different African sources as well. But this is sort of where it all started, the Center for Mindfulness with John Kabat-Zinn. They have a very comprehensive training program. And just to give you a sense of the requirements keep getting stiffer and stiffer to be certified. Right? When I did it back in 1998, half this didn't even exist. So I'm not technically certified, but I'm grandparented because I've been doing it for so long. But you start with completing an 8-week course as a participant. And then you have to do all these things to get their certification. So be a participant observer. They have like a 7-day retreat, classes, workshops, academic study. I think a key here right from the beginning is that having ongoing regular mindfulness practice yourself, your personal practice, as well as yoga. They have these things called teacher development incentives. You can see, it adds up, right? And it's also not inexpensive. And then they have phase 3, where they want you to teach at least 4 complete 8-week classes under supervision, and continuing with your development through self-assessments. And then they have another phase where they want you to do at least 8 complete courses, meditation retreats, et cetera, et cetera. So this is to get their stamp of approval. And I don't think everyone has to do this to be able to teach mindfulness. Really, I think having a personal practice is useful. I think having been through an MBSR program is useful. And so what we've been working on is lately, for many, many years, Michael Speck and I have been asked, do we train people in MBCR? And the only way we've been doing it is to have them come to our center and be participant observers in our 8-week program. But that means you have to come to Calgary for 8 weeks, right? And that's not practical. So we have been developing now a new online course, and there's a website there that talks about it's not ready yet. But what we're doing is we already have recordings of our actual classes, because we've recorded them for research study purposes, and we have permission from all the participants to use them for training. And so we already have those sessions, and they're really useful for people to watch those sessions to see us in action. But we're also adding in all these introductory videos that we're making right now. So one video is about background, about teaching principles. And then for each session, we have an introduction, 5 or 10 minutes, where Michael and I say, okay, this is what's going to happen in the session. Look for this, look for that. And then they get to review the 9 sessions in, real live patients. And then we're having a monthly live Q&A where anybody who's in the training program can come and ask us questions and just chat. So it should be ready. We're hoping to launch it in January. And I think that we get emails all the time. So hopefully there'll be interest in that. So I'm going to summarize. Mindfulness is a good approach to address many problems specific to people with cancer. MBCR is an adaptation of MBSR. We know it's effective for a variety of symptoms. We need to do more pragmatic research to aid implementation and spread of these kind of programs. And so online and mobile adaptations might be a way to help reach more people. So it looks to me like we've got about 10 minutes left. This is a prompt to do a little loving kindness, and maybe we will, unless we want to break for questions. I don't know, Chioma, Melissa, what's your preference here?
Hello. Hi, thank you so much. I guess we can see if there are any questions from the audience.
Why don't we do that? If there's any pressing questions, I can address those. If there's not, I'll just take us out on a little loving kindness practice.
Yeah, that would
Yeah,
be interesting.
I just think that we should do the loving kindness practice.
Okay. All right, let's do that.
All right, I'll do it. Okay, so again, just get yourself seated in an upright position, feet flat on the floor. If you're able to, just make space in your chest for the breath. And focus your attention right in the center of your chest, what we might call the heart center. Right by the sternum or your breastbone. And just feel the breath moving in and out of that heart center. And notice if there's any sensation there. You may feel, I don't know, a warmth or a sort of vibration, or maybe not. And let's begin by starting with ourselves. So with your eyes closed, maybe just bringing an image to mind of yourself and your own struggles. You know, the ways that you've been challenged, whatever you might be going through right now. And you can perhaps feel that in your heart, your concerns, and you can imagine approaching yourself as if you're a small child that you would wish to comfort. So both recognizing your own vulnerability and also your own strength. And with each breath in and out, repeating silently to yourself these phrases. So as you breathe in, may I be free from suffering. And as you breathe out, may I be at peace. May I be free from suffering. May I be at peace. And just sticking with that simple phrase for a few breaths, and just notice how that lands, how that feels in your heart center. And adding in another phrase, may I be happy, may I live with ease. So may I be free from suffering, may I be at peace. May I be happy, may I live with ease. And now just bringing to mind a loved one, a family member, a close friend, even a pet, and allow their image to crystallize in your mind's eye. And notice how that feels in your heart center. Does it feel warm or expansive or opening, perhaps? And so then sending that same wish to your loved one. May you be free from suffering. May you be at peace. May you be happy. May you live with ease. And imagine with each breath that circles of kindness, compassion from your heart, just expanding and reaching across time and or space and even time to your loved one. Imagine your loved one receiving this wish for their well-being, being embraced by your loving kindness. May you be free from suffering. May you be at peace. May you be happy. May you live with ease. And as you do this practice, you can repeat any phrases you like that resonate with you. And only because we're out of time, we'll stop there. But traditionally, we would continue and we would expand the circle of compassion until we included all beings with the phrase, may all beings be free from suffering, may all beings be at peace. So I will leave it there, I think, for the interest of time, but that gives you a taste of that, I think. I'll turn it over to our moderators.
Thank you so much to all the presenters, Scott Nichols, Chioma Azuzu, Linda Carlson. It's been a true pleasure. I wish everyone to be at peace and to enjoy the conference. We will be having another special session in psycho-oncology tomorrow. It will be from 11 to 12 South African time. And we will have the pleasure then to welcome our WHO officer for Sub-Saharan Africa, Prebo Barango, an oncologist. We will also have a session also outlining a special training program that we have developed for people in Africa to continue on our capacity building. We will have also our past president of the International Psycho-Oncology Society. So I would invite you all to this symposium tomorrow. And I wish you an amazing day. And again, be in peace and thank you all. I don't know if Dr. Aziz would like to say a few words.
Thank you to the facilitators. It truly has been an invigorating day today, starting with the trials of managing patients with cancer, and especially after the pandemic. And I think we close this session off with a very reassuring presentation on how to try and on psycho-oncology, how we can improve our patients' psychological, emotional, and physical well-being by trying these methods like asking patients and understanding how patients feel. And for me as a clinician, you know, I always usually say to patients, remain positive. And I never thought of the implications of expecting patients to be positive when there is really no room for being positive. I particularly like the idea of the pleasant events log, that one does not remain negative. But I truly appreciate that sometimes one really cannot get out of the dungeon of being negative, and that for me as a clinician, I have to be aware of all this. And it has taught me about the difficulty faced by both the clinicians as well as patients when they are diagnosed with cancers of any kind. Thank you for this session. I truly enjoyed it. And to the facilitators, thank you once more.
So to wrap up, and finally, is to thank you everyone for active participation today. And we'll see you back tomorrow here at 10 a.m. South African time. Good night. Have a good evening. Thank you.
Thank you.